is Dr. John Bennett. We're broadcasting for Larkin Hospital TV. Today we have the first in the channel of ENT. We have the honor of having Dr. Hee-Young Kim. He's an ENT specialist from Seoul, Korea. And he's going to talk about Eustachian Tube Catheterization. We have a couple of distinguished panelists who we're going to introduce now. First, we'll start with Simon.
Hello everyone, my name is Simon Downs. I'm in Tokyo, Japan. I'm a developmental clinical psychologist and also a medical student. Nice to meet you all.
And a frequent participant in these hangouts. Welcome, Simon. Mohammed.
Good morning, everyone. My name is Mohammed Saleh. I'm a medical doctor joining today from Toronto. Nice to be with you today.
And Mohammed's done some Arabic hangouts with noted Parkinsonism educator Dr. Rana, which can be seen on the Parkinsonism and Neurology channel. And the guest of honor, Dr. Hee-Young Kim. Welcome, Hee.
Hi, hello. My name is Hee-Young Kim. I have practiced patients in my private ENT clinic in Seoul, Republic of Korea. Sharing my idea and the experience of 20 years with you is my great pleasure now. Expecting to interact with one another, I'm happy to answer questions if there are any. Please type your questions on the chatting window of the right side of the screen, even though I'm speaking. Where it is in the works, I will share screen.
Okay.
Okay, do you see?
There you go. Yes, it looks good.
Yes, okay, I will start. Thank you, Mr. Chairman, and Mohammed and Simon. Good morning. Today, I'd like to talk about the Eustachian tube catheterization. My own experience has proved that many cases of both laryngopharyngeal reflux, LPR, and Eustachian tube obstruction, or ETO, at the same time. And I realized all the more keenly the necessity of defining the cause and effect relationship between both of them. And it should be universally applicable to the management of many cases of this type. Because Eustachian tube catheterization may be of both diagnostic and therapeutic value, ETO should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. We will discuss Eustachian tube catheterization with devices like a Eustachian tube catheter and a Toynbee diagnostic tube. To begin with, let's look at the anatomy and physiology related to Eustachian tube. The ear is the organ that detects sound. It not only receives sound, but also aids in balance and body position. The ear is part of the auditory system. You can look at the Eustachian tube, tympanic membrane, tympanic cavity, and stapes attached to oval window. The middle ear is an air-filled cavity behind the tympanic membrane. Includes three bones, ossicles, the malleus, and incus, and stapes. The middle ear also connects to the upper throat via the Eustachian tube. The Eustachian tube connects from the chamber of the middle ear to the back of the nasopharynx. The middle ear is very much like a specialized peronasal sinus, called the tympanic cavity. It, like the peronasal sinuses, is a hollow mucosa-lined cavity in the skull that is ventilated through the nose. Tympanic cavity and mastoid cavity are named on the basis of anatomy. However, if we view things from a different angle, we can regard them as one of the peronasal sinuses called tympanic sinus, like maxillary or frontal or ethmoid or sphenoid sinus, in a view of physiology and function. This point is the reason why I spot the theory of sinus headache when I need to explain the cause of headache from Eustachian tube obstruction. The bunny labyrinth or osseous labyrinth is the network of passages with bunny walls lined with periosteum. The membranous labyrinth runs inside of the bunny labyrinth. There is a layer of perilymph fluid between them. The three parts of the bunny labyrinth are the vestibule of the ear, the semicircular canals, and the cochlea. In the middle ear, the energy of pressure waves is translated into mechanical vibrations by the three auditory ossicles. Pressure waves move the tympanic membrane, which in turn moves the malleus, the first bone of the middle ear. The malleus articulates to incus, which connects to the stapes. The foot plate of the stapes connects to the oval window, the beginning of the inner ear. When the stapes presses on the oval window, it causes the perilymph, the liquid of the inner ear, to move. The vestibular system of the inner ear is responsible for the sensations of balance and motion. It uses the same kinds of fluids and detection cells as the cochlea uses and sends information to the brain about the attitude, rotation, and linear motion of the head. The type of motion or attitude detected by a hair cell depends on its associated mechanical structures, such as the curved tube of a semicircular canal or the calcium carbonate crystals or otolith of the sacule and utricle. Anatomy of Eustachian tube. The Eustachian tube, also known as the auditory tube or pharyngotympanic tube, is a tube that links the nasopharynx to the middle ear. It is a part of the middle ear. In adult humans, the Eustachian tube is approximately 35 mm long. Normally, the Eustachian tube is collapsed, but it gaps open both with swelling and with positive pressure. When taking off in an airplane, the surrounding air pressure goes from higher to lower. The air in the middle ear expands as the plane gains altitude and pushes its way into the bag of the nose and mouth. On the way down, the volume of air in the middle ear shrinks and a slight vacuum is produced. Active opening of the Eustachian tube is required to equalize the pressure between the middle ear and the surrounding atmosphere as the plane descends. A portion of the tube proximal to the middle ear is made of bone. This bony part is about 12 mm in length. It begins in the carotid wall of the tympanic cavity, below the septum canalis musculotubuli, and gradually narrowing ends at the angle of junction of the squama and the petrous portion of the temporal bone. Its extremity presenting a jagged margin, which serves for the attachment of the cartilaginous portion of the rest of the tube. and this raises a tubal elevation, the torus tubarius, in the nasopharynx where it opens. The cartilage of pharyngotympanic tube, about 24 mm in length, is formed of a triangular plate of elastic fibrocartilage, the apex of which is attached to the margin of the medial end of the osseous portion of the tube, while its base lies directly under the mucous membrane of the nasal part of the pharynx, where it forms an elevation, the torus tubarius or cushion behind the pharyngeal orifice of the tube. The base of the cartilaginous portion of the Eustachian tube, pharyngotympanic tube, or auditory tube, lies directly under the mucous membrane of the nasal part of the pharynx, where it forms an elevation, the torus tubarius, the torus of the auditory tube, or cushion behind the pharyngeal orifice of the tube. Two folds run posteriorly and anteriorly to torus tubarius. Posteriorly, the vertical fold of mucous membrane is the salpingopharyngeal fold. Anteriorly, the second and smaller fold is the salpingopalatine fold. There are 4 muscles associated with the function of the Eustachian tube. The tense belly palatini tenses the soft palate, and by doing so, assists the levate belly palatini in elevating the palate to occlude and prevent entry of food into the nasopharynx during swallowing. The tensed palate consequently provides a stable platform for elevation of the pharynx during swallowing by the pharyngeal muscles. Since it is also attached to the lateral cartilaginous lamina of the auditory tube, it assists in its opening during swallowing or yawning to allow air pressure to equalize between tympanic cavity and the outside air. Equalization of air pressure in the tympanic cavity is essential for preventing damage to the tympanic membrane and the resulting loss of hearing acuity. Physiology of Eustachian tube. Under normal circumstances, the human Eustachian tube is closed, but it can open to let a small amount of air to prevent damage by equalizing pressure between the middle ear and the atmosphere. Pressure differences cause temporary conductive hearing loss by decreased motion of the tympanic membrane and ossicles of the ear. This point includes clue for explaining the mechanism of tinnitus due to Eustachian tube obstruction. Improvement of tinnitus after Eustachian tube catheterization can mean that the tinnitus is from the hypersensitivity of cochlear nucleus following decrease of afferent nerve stimuli owing to airborne gap. The Eustachian tube has at least 3 physiologic functions with respect to the middle ear. 1. Ventilation of the middle ear to equilibrate air pressure in the middle ear with atmospheric pressure. 2. Drainage and clearance into the nasopharynx of secretions produced within the middle ear. And 3. Protection from nasopharyngeal sound pressure and secretions. Eustachian tube obstruction. When you swallow or yawn, the tubes open briefly to let air in to make the pressure in the middle ears equal to the pressure outside of the ears. Sometimes fluid or negative pressure gets stuck in the middle ear. Mechanical obstruction of the Eustachian tube may be either intrinsic or extrinsic. Intrinsic mechanical obstruction is usually caused by inflammation of the mucous membrane lining of the Eustachian tube or an allergic diathesis causing edema of the tubal mucosa. Extrinsic mechanical obstruction is caused by obstructing masses such as hypertrophic adenoid tissue or nasopharyngeal tumors. Although ETO is one of the principal causes of hearing loss and/or ear fullness and/or dizziness, vertigo, and/or tinnitus, and/or headache, migraine, including otalgia, has already been recognized by many well-respected senior doctors for a long time. It has still received only scant attention both in the literature and in practice. Some mentions that an example of dizziness induced by middle ear pressure fluctuation is alternobaric vertigo, such as occurs in people who can clear one ear but not the other. This is mainly a problem in scuba divers and airplane pilots. They think that pressure sensitivity is a symptom, not a disease. So it tends to be regarded as a normal variant. However, we need to study a question in its broader aspects, especially in cases complaining of nausea, vomiting, and perspiration accompanied concomitantly by vertigo, which are attributable to ETO. Their physicians tend to fail to recognize the cause in the emergency room or outpatient clinic. What's even worse, many special clinical tests of vestibular function are performed even in the case such as vertigo due to ETO. There are many other conditions which may cause vertigo, but since Eustachian tube obstruction is one of the most obvious and also the most easily corrected, every patient with symptoms of vertigo and/or nausea and/or vomiting and/or perspiration should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Dizziness or vertigo from ETO can be explained by an increase of inner pressure of the vestibular organ. It is because negative middle ear pressure gives rise to the retraction of the tympanic membrane, and it makes the stapes push against the oval window. You can then, under this figure, you can watch the pedolymph, orange-colored area, and endolymph, blue-colored area. It seems obvious that obstruction of the Eustachian tube somehow disturbs the air pressure and causes stimulation of the pedolymph, which interferes with the normal balance as maintained by the labyrinthine mechanism. The otolith membrane is part of the otolith organs in the vestibular system. The otolith organs include the utricle and the sacule. The otolith organs are beds of sensory cells in the inner ear, specifically small patches of hair cells. Overlying the hair cells and their hair bundles is a gelatinous layer, and above that layer is the otolithic membrane. The utricle serves to measure horizontal acceleration, and the sacule responds to vertical accelerations. The reason for this difference is the orientation of the macula in the two organs. You can watch the utricle and the sacule. It seems likely that this syndrome due to ETO is either caused by asymmetry in inner ear pressure, accompanying changes in middle ear pressure, or due to displacement of otolithic membranes associated with displacement of the ossicular chain, accompanying an inequality between middle ear and external ear pressure. The linear acceleration could be in the horizontal direction, as in a moving car, or vertical acceleration such as that felt when an elevator moves up or down. Recognition of the head's movement relative to the body is provided by the linear otolithic macula and angular semicircular canals, acceleration receptors of the inner ear. Electrical activity generated within the inner ear travels along the vestibular nerve, primary afferent neuronal pathway, to the central vestibular nuclei of the brainstem, forming second-order neuronal pathways that become the vestibulo-ocular reflex, the vestibular spinal tracts, and the vestibular cerebellar tracts. Pathways derived from vestibular information also travel to the brainstem emetic centers, or nucleus solitarius, blue-colored area, which serves to explain vegetative symptoms such as nausea, vomiting, and perspiration that a patient typically experiences following an acute unilateral vestibular loss, originating from acute unilateral Eustachian obstruction. This acute unilateral vestibular loss can be from acute unilateral Eustachian obstruction. We can realize that electrical activity generated by ETO travels to the brainstem emetic centers and cause vegetative symptoms such as nausea, vomiting, and perspiration after all. Here, we need to remember this clear proposition that ETO is the obvious cause for loss of vestibular function. Unilateral ETO, unilateral peripheral vestibular loss. With the loss of unilateral vestibular function, the patient acutely experiences the sensation of true vertigo from interruptions of VOR pathways and tends to lie perfectly still, as any movement aggravates vegetative symptoms such as nausea and vomiting that arise from the emetic centers. The stigmus beating away from the side of lesion is the cardinal physical sign that obeys Alexander's law. The vertigo is caused in most instances, and perhaps in all, by unilateral Eustachian obstruction or by more complete obstruction on one side than the other. The direction of the gate furnishes a clue to the side which may be affected, for in most of the cases, the staggering is in the direction of the obstructed side, with compensation implying the existence of a normal functioning CNS and contralateral peripheral vestibular system. There may be minimal symptomatology that is only brought out by very rapid head movements. The spontaneous nystagmus disappears, vegetative symptoms resolve, gait improves, and in the case of a chronic condition, the patient may experience only a slight imbalance when turning quickly. This point can be the reason why any vestibular function test should never be performed before correction of ETO and without normalization of middle ear pressure and tympanic membrane retraction. Bilateral peripheral vestibular loss. Vertigo is not a feature of bilateral vestibular loss even when it occurs in an acute fashion. In one case of acute bilateral obstruction of Eustachian tube I experienced, A woman could not walk well and staggered to me in my clinic. She complained of severe vertigo, nausea, vomiting, and perspiration. The result of tympanometry was flat B-type in both ears. In an acute case, it doesn't matter if the obstruction of the Eustachian tube is unilateral or bilateral. Injury to the end organs, as might occur in systemic aminoglycoside vestibular toxicity, causes a bilateral loss of function that tends to be electrically symmetric at the level of the vestibular nuclei in the brainstem. Instead, the patient tends to complain of oscillopsia, visual blurring with head movement, and imbalance. The gait is typically broad-based and ataxic, especially with eyes closed. Falls are not infrequent, and in many instances, the patient requires assistive devices for ambulation or is relegated to a wheelchair. Compensation is generally unlikely to occur despite the best efforts of vestibular rehabilitation therapy and a greater reliance on information from visual and proprioceptive receptors. Talking of the two considerations, to wrap it up in a nutshell, changes in middle ear pressure and negative middle ear pressure, and an inequality between middle ear and external ear pressure, and retraction of tympanic membrane, and displacement of the auricular chain, and the stapes push against the oval window, and stimulation of the pedal lymph, and increase of inner pressure of vestibular organ, and displacement of otolithic membranes, and asymmetry in inner ear pressure, and interferes with normal balance as maintained by the labyrinthine mechanism. While vertigo originated from EPO is a distinctive clinical entity, doctors ignore the possibility that the violent symptoms of dizziness, nausea, vomiting, and perspiration can be originated from EPO. The reason is that some of the physicians, audiologists, otolaryngologists, or even otologists are likely to think in terms of disturbances in the digestive, circulatory, nervous systems, or only vestibular organ function, and usually examine them without considering other possibilities. The cases of insidious onset are the ones most likely to be overlooked in these instances because the gastrointestinal symptoms are predominant. The patients because the gastrointestinal symptoms are predominant, the patients are likely to be subjected to various types of treatment over long periods for diseases of the digestive system. The gastrointestinal symptoms of the cases of insidious onset can also be regarded as symptoms of LPR or GERD. Hence, we can accept on Cartesian intuition that every variable symptom and disease associated with LPR or GERD should be included in the multiple symptoms and diseases originate from ETO. We must pay attention to the necessity that the cases of insidious onset are first subjected to Eustachian tube catheterization. Next slide. The symptoms of LPR are protean. However, the most common are hoarseness, globus pharyngeus, dysphagia, cough, chronic throat clearing, and sore throat. The most common manifestation of LPR is reflux laryngitis, with or without granulation or granuloma formation. In addition, the reflux has been reported to be associated with subaortic stenosis, laryngeal carcinoma, polypoid degeneration, laryngospasm, paradoxical vocal fold movement, and vocal nodules. Other manifestations in the head and neck that have been reported include asthma, sinusitis, and otitis media. I believe that more variable symptoms related to both of LPR or GERD, e.g. back pain and numbness of fingers or toes, than many symptoms gaining academic recognition at present need to be proved definitely. On the grounds that LPR or GERD can be the direct result of the ETO, I strongly urge that ETO should be included as a direct cause of LPR or GERD academically. In the patients having both LPR and ETO, ETO is not just a cause of LPR as seen above. On the contrary to this, LPR can be a cause of intrinsic mechanical obstruction of Eustachian tube, because reflux contents from stomach can reach the nasopharynx and the Eustachian tubes through esophagus and block the tubes directly or cause inflammation of the mucous membrane lining of the Eustachian tube or adhesion and collapse of it. Therefore, the concept of reciprocal causal relationship, both of LPR and ETO, which cause a vicious cycle, is established distinctively. Treating patients regardless in an emergency room or outpatient clinic, a wide and diverse variety of symptoms originating from LPR or GERD and ETO has to be considered with the mutual connection observantly. As mentioned earlier, because Eustachian tube catheterization may be of both diagnostic and therapeutic value, they should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Ideally, normal middle ear cavity pressure with a perfectly equal balance between both ears is the core prerequisite before diagnosis and treatment for any symptom and disease. Moreover, it is established that every clinical test being used in the assessment of vestibular function should be performed in the state of ideally normal middle ear cavity pressure with perfectly equal balance between both ears. This proposition has to be checked before any other test for vestibular function, tinnitus, ear pulleys, sensory neuronal hearing loss, headache, ear aches, itching sensation of ear, migraines, vertigo, etc. Any vestibular function test should never be performed before correction of ETO and without normalization of middle ear pressure and tympanic membrane retraction, because ETO can already cause a loss of abnormality of vestibular function. Let me show you these Eustachian tube catheters, which I use myself in my clinic at present. There are 4 sizes. The number and colored mark of each catheter is scaled according to the diameter of catheter. Toynbee diagnostic tube. This is a stethoscope-like device used to examine and listen to the Eustachian tube for tinnitus. How is Eustachian tube catheterization done? This procedure is more than a century old and was earlier routinely done to check patency of the Eustachian tube. You can find Eustachian tube and Rosenmuller fossa. The tip of the catheter is inserted into the nose and passed along the floor of the nasal cavity till it touches the posterior pharyngeal wall. The tip is now in the nasopharynx. At this point, the tip is rotated 90 degrees laterally so that it touches the Rosenmuller fossa behind the Eustachian tube in the lateral wall. The tip is pulled slightly and passes over a gentle slope. This slope is torus tubarius, so that it enters the opening of the Eustachian tube. A police bag or ventilator is attached to the other end of the catheter. Air pushed from it can be heard rushing into the ear if the Eustachian tube is patent. The operator can confirm this sound with the Toynbee diagnostic tube. The medial and the lateral rotations that appear to complicate the procedure were actually designed to avoid the tubal elevation located behind the tubal opening, since the tip cannot be seen once inserted into the nose. The original procedure was a blind one, with only the metal ring to indicate the direction of the catheter's tip. But the procedure can also be done under endoscopic guidance. This is me. Now I'm practicing Eustachian tube catheterization in my private clinic. I'd like to thank you very much for your attention.
All right, Hee. Thank you very much, Dr. Kim. Excellent presentation, well illustrated, really good slides, and you know, for the students, you know, it really is important to know the anatomy and the physiology of the inner ear, because you're going to see a lot of ear problems in your career, and I think Mahmoud will agree that it's just such a common problem, so it would help. Okay, questions from the audience?
Okay, chatting window.
Okay, sure. I have two questions here. I'm gonna type them. Let's start.
Okay.
Can I stop screen sharing?
Oh, you're gonna type it in for Hee? Okay.
I'm typing it, and I'm gonna say it again. So the first question that I have is, first, thank you for an excellent presentation. I really like myself the slides and all the anatomy and this. My first question would be, what are the common contraindications for Eustachian tube catheterization? And
indication?
Contraindications.
Indications. This is the first question. And the second question would be, what are some common complications from catheterization?
Okay. I have thought about Eustachian tube catheterization. It has both diagnostic and therapeutic value. So I don't think that it has contraindications.
There's none. There's no contraindications to catheterization.
Maybe complications can happen in any cases, any patients, because poor technique of Eustachian tube catheterization.
Okay, I imagine you can tear some tissue in there, correct?
Damage to tissue.
You can cause damage to the Eustachian tube if you're not careful.
people who need Eustachian tube catheterization, most of them are rhinitis.
Oh, they're very skilled. Very skilled.
So inflammation of mucosa. So they have weak point already weak point.
Oh, okay.
So yes.
Okay.
Yes.
Okay. Very good.
They can have damage to Eustachian tube catheterization, but it is not problem. I think so.
Does
Okay.
that heal fast in case like a little inflammation, irritation?
What was the question again? What was the question?
If we were to get some like inflammation, irritation, does it heal fast or does it like?
Do you mean the inflammation due to complication?
Exactly.
Or,
yes.
I don't think the inflammation due to complication.
So it's a relatively safe procedure.
Safe procedure.
Yeah.
Okay.
Yeah.
Okay. Very good. Very good. More questions? Fred? Oh, Fred Kim Ladies, a medical student from Belgium. Hello, Fred.
Hi guys.
Hello. Yes.
Yeah, well,
Hi,
just arrived later, so was really interesting, really clear as well. Yeah, I couldn't really follow it all, so don't really have some questions, but was really interesting though.
Thank you.
Yeah, you're going to see a lot of it, Fred. A lot of ear problems.
Yeah, probably.
Yeah. Simon?
Yes, thank you, Dr. Kim, for explaining what to do in the case of Eustachian tube obstruction and how to use Eustachian tube catheterization. I was wondering, after the procedure is finished, would you prescribe some medications such as NSAIDs or any antibiotic, just in case?
I used anti-inflammatory drug and antihistamine and mucolytics. Sometimes I use antibiotics.
I see. Thank you.
Yes.
Okay. Any like cephalosporins? Do you use those, Dr. Kim? Or Septra? I don't know if it's the same medication in Korea, but here it's a sulfa drug or a cephalosporin. Do you use those post-op or post-procedure?
In otitis media, I usually use the second generation Cefugil.
Second generation cephalosporin.
Yes, Cefugil. I know the trade name is Cefugil.
Okay.
Yeah. I like it.
Very good. Dr. Kim, click on your screen share so you can get off the screen share so we can see your handsome face.
Can I stop? Okay.
Click on the screen share. There you go. There you go.
Thank you.
There you go. Yeah, I'd like you to meet you. You see Fred there from Belgium, and Mahmoud. There's a general surgeon from Greece to your right.
Yes.
Can you say hello to Dr. Kim, Mahmoud?
Mahmoud.
You have to unmute your microphone. Unmute the mic. There you go.
Hello, everybody. This is Dr. Mahmoud from Greece.
Good morning.
It's really
nice
a
to
nice
meet you.
presentation. I would like to congratulate you, Dr. Kim. It's a good and fantastic presentation.
Thank you very much.
Yeah, Mahmoud gave an excellent one yesterday on laser surgery, which I'll send you the link, Dr. Kim. Do you have any questions, Mahmoud, or comments besides a good presentation?
No, I just
Nothing
want to,
specific?
because I was not in the presentation from the beginning.
Okay.
I want Dr. Kim to mention again the indications of the catheterization.
Indication?
Yeah.
Is it recurrent infections, Dr. Kim? Would that be an indication
Dizziness.
for something like this? Recurrent, a child that has many ear infections, would that be probably number one, wouldn't it?
It is diagnostic.
If you had a child that had many ear infections, would you consider that an indication for Eustachian tube catheterization?
Child? Do you mean child?
Well, yeah. A child that has many ear infections.
I practice it on the topical anesthesia.
Okay.
I use mixed epinephrine and lidocaine. Help and help.
Okay.
Children has no intervals, so most of them I don't practice it.
Oh, okay.
Some child can have because they're good patients.
Well, you know, Dr. Kim, I'm going to make a comment, and maybe the other panelists will have something to say. But I remember when I worked in the emergency room, I would see a lot of children with Eustachian tubes, with tubes.
Yes.
Many. Is it the same way in Korea? It seems very. Is it? Have you guys had that experience too? You see a lot of children with ear tubes.
I've done it during my pediatric rotation. I've seen a lot of children, like Dr. Bennett is saying, with the tubes.
Yeah. I don't know if it's as common in other countries. How about Simon? Do you notice that in Japan?
No, I haven't seen it. This is new to me.
Not too much. How about you?
When you say
have you seen many patients, Fred, with
yeah, quite a lot. It's quite a lot, but now there was a recent study where they found out that whether or not they would use it, it wouldn't benefit as much in the longer term. Right. So they're kind of stepping off from it here. I don't know what's it like in other parts of the world. So
yeah, I know it's in the United States they're trying to get away from it because obviously an invasive procedure that can cause problems, and that I think many doctors feel it's overdone here in the United States. But I don't know. Is it very common, Dr. Kim, in Korea to put the tubes in? Is it common or only rarely?
For Eustachian tube catheterization?
Yeah, is it common? Is it very common?
Yes, very common. I emphasize that both the LPR, GOD, and ETO have them at the same time.
Oh, okay.
There are many. I experienced there are many patients.
Oh, okay.
If you have pay attention to them, you can visualize it. Go in LPR or go the patients. If you check the video pressure for Eustachian tube obstruction, you can find there are many people. Mm-hmm. I believe it.
Okay, very good, Dr. Kim. I'd like to thank you very much for an excellent presentation, well illustrated, and I can understand all your English. Your English is very good, and it's getting better. And we look forward to you giving more presentations in ENT and also participating in the panel. I'd like to thank all the panelists for coming, and stay tuned for the next show on Larkin Hospital TV.
Thank you all.
Good day, gentlemen.
Thank you.
Thank you very much.
Thank you,
everyone.